Next, my dear colleagues, I'd like to introduce our next speaker, and I'd like also to apologize to all of you for running a little late on the program. And inshallah, hopefully we'll make it up when it comes to the lunch break session. We can readjust. Our next speaker is Professor Ian Pavord from University of Oxford. Our next speaker is the Professor of Respiratory Medicine at the University of Oxford and an honorary consultant at the University of Oxford Hospitals. He is the co-editor of the famous Thorax Journal from 2010 to 2015, and he's the Chief Medical Officer of Asthma UK from the year 2008 until 2014. Professor Pavord really influenced me by his talks in international meetings, and he has this revolutionary themes on airway diseases and the topic of a new topic that scientists has been discussing over the past few years, and that is the topic of treatable traits. And what he's trying to tell us is that there are treatable traits in patients with airway diseases, chronic airway diseases, that join and are in common between either asthma or COPD patients. And it might be worth looking into treating patients, looking at their traits, whether they have asthma or COPD, and the treatment agents might do the same benefit. It's a revolutionary theme, a lot of pros and cons, and that's why I thought it would be very interesting to get the expert here with us today to try and convince us, or we can argue against that. Professor Pavord, it's an honor and privilege to have you here with us today in UAE and our colleagues across in the region. The floor is yours.
Thank you very much, Professor Alzabi, and thank you to the organizers of this excellent conference for giving me this opportunity to talk about a new way of thinking about airways disease and organizing our management, the treatable traits concept. I do have some relevant conflicts of interest that you need to be aware of before we move on, and these are set out on this slide. Now, for me, the catalyst for this change in thinking was the clinical development of mepolizumab, a monoclonal antibody that blocks IL-5 and thereby reduces eosinophilic airway inflammation. Now, initial clinical trials of this biologic agent were carried out in patients with asthma. By that, I mean bronchodilator responsive airflow limitation, and looked at an outcome measure linked to that characteristic, the morning peak expiratory flow. And the initial study in moderate asthma was negative. So there was no effect of mepolizumab against morning peak expiratory flow, not low or high dose mepolizumab. Yet when this agent was trialed in patients who had eosinophilic airways disease against an outcome measure that we felt was linked to eosinophilic airway inflammation, that is the occurrence of asthma attacks, you can see there was clear evidence of efficacy. Now, it seemed to me that when we had a system for stratifying airways disease and thinking about airways disease that resulted in us nearly missing the large clinical benefits of a drug like mepolizumab, we had a problem. And it was clear that what needed to happen and the change in thinking that led to the discovery of the efficacy of mepolizumab was the recognition that eosinophilic airway inflammation and the abnormality of airway function that we use to define asthma are relatively independent treatable traits that relate to different outcome measures in different ways. So eosinophilic airway inflammation more closely linked to the occurrence of asthma exacerbations, whereas the abnormality of airway function was more closely linked to day-to-day symptoms. And this schema suggests that we will never optimize management of asthma and perhaps also COPD until we recognize that these traits are relatively independent and need different management approaches. So that was the basis of the treatable trait movement, if you like. And you can see on the left a meeting in Barcelona in 2015 with a number of my friends and colleagues where we fleshed out the concept of treatable traits. And it was very much the focus of the Lancet Commission on asthma that I was very fortunate to chair and which reported in 2018. And we define a treatable trait as a measurable aspect of the disease that can be modified with the result that the patient derives some clinical benefit. And when it comes down to it, in obstructive airways diseases, there are two dominant treatable traits. On the y-axis, we have the risk of attacks of asthma or COPD as a result of eosinophilic airway inflammation. And this risk can be assessed using biomarkers of type 2 eosinophilic airway inflammation. And on the x-axis, we have symptoms that are due to airflow limitation, and that can be assessed with symptom scores and spirometry. And you can see if you assess these two dominant treatable traits, you're in a good position to start offering individualized, if you like, precision medicine. So your approach for a patient who has symptom predominant disease, and I agree with the last speaker, that this group of patients sit particularly in the COPD clinic, you would offer a bronchodilator heavy management approach with perhaps dual bronchodilators. Whereas if your patient sits in the inflammation predominant pattern of disease, and we see a lot of this in the severe asthma clinic, then you would offer a more anti-inflammatory heavy management approach with inhaled steroids and biologic agents. So perhaps if we can start doing this, we can get better outcomes with existing treatments. But I think there will be additional benefits of this approach, which I'll touch on at the end. Now, I think there are some important considerations in 2021, and that is that GOLD in 2019 and the GINA severe asthma guidelines in 2018 already recommend that we do this. So treatable trait-based management is already out there and being carried out in a great many patients. The other change, I think, is that we now recognize that we have two very valuable and clinically accessible biomarkers of type 2 airway inflammation, one of the dominant treatable traits. And it's become clear that these biomarkers, and they are the blood eosinophil count and exhaled nitric oxide, have got established prognostic and predictive value. They identify people at risk of asthma attacks, and they identify a treatment opportunity. And the final point I would make, which is particularly relevant in the UK, is that non-specialist clinicians such as GPs are actually very good at biomarker-directed management. They do this all the time in cardiovascular medicine, where in the UK, they have delivered a 70% reduction in mortality in the last 10 years in adult males from ischemic heart disease. And during that time, I would add, in airways disease, we haven't seen much improvement in our mortality figures. And of course, this improvement in cardiovascular outcomes has been driven by biomarker-directed management, cholesterol and blood pressure and targeted treatment. Now, the biomarkers, blood eosinophil counts and FeNO, are in many ways the airway cholesterol and blood pressure. They identify risk that you can be reduced with treatment. Now, I show here 3 analyses that have been carried out very recently. On the left, an analysis in patients with mild asthma who are treated with as-needed bronchodilators only. And on the right top, an analysis in moderate to severe asthma, and the bottom in COPD. And what they all show, if we focus on the left, is that with increasing biomarker, in this case, the blood eosinophil count, you can see a progressively increasing risk of asthma attacks. I want you to look at the blue columns. This is the group of patients that are treated with as needed salbutamol only. And there's between a 4- and 5-fold increased likelihood of a severe exacerbation if you have a high blood eosinophil count compared to a low. And I don't know why we don't want to know this. It seems to me a very important bit of information, particularly as if you use an inhaled steroid, and it's shown in brown, this excess risk associated with a biomarker is completely eliminated. And it's the same story in COPD. You can see an increased risk with increasing blood eosinophil counts, which is completely removed by the use of an inhaled steroid. And in moderate to severe asthma, you will see that the increased risk of asthma attacks is seen with FeNO and blood eosinophil counts, and they have additive value. So if you measure both biomarkers, you're in a better position to prognosticate than if you measure one. And they also have additive predictive value. So the benefits of biologic treatment, whether it's dupilumab or mepolizumab, are greater if you have 2 raised biomarkers than if you just have 1. In COPD, we've already seen the impact study and clear evidence from over 10,000 patients that if you have a higher blood eosinophil count, there are real benefits of having an inhaled steroid, whether it's in a dual LABA-ICS or in a triple LABA-ICS-LAMA. Whereas if you have low blood eosinophil counts, the benefits of dual bronchodilators seem to be greater. And there is little evidence that inhaled steroids add anything to dual bronchodilators. And now, of course, and we've seen this, GINA recommend that decisions about the use of inhaled steroids are in part driven by the peripheral blood eosinophil count. So if you perceive the risk of exacerbations to be high, you would give an inhaled steroid if the blood eosinophil count's above 100. If you think it's moderate, you would probably use a higher threshold of 300 before you use the inhaled steroid. So this is treatable trait, biomarker-directed management out there in real time and in clinical practice, and I think a very important development. Now, having decided to use an inhaled steroid, the next question is how should you titrate the dose? What should be your goal of treatment? Now, traditionally, GINA says that we should target symptoms, what I call chasing the symptoms, failing to recognize that in around 40% of patients with asthma, it is completely impossible to normalize symptoms. So in many cases, we are chasing an unattainable goal, which will mean that we ratchet up the dose of inhaled steroids to very high levels. This is a meta-analysis published recently in Thorax, which looked at a different management approach where the goal of treatment was to suppress exhaled nitric oxide to normal levels. So you had a biological target rather than the clinical target. If you like, a bit like using blood pressure to assess the efficacy of a blood pressure lowering treatment rather than symptoms. And you can see that FeNO-guided management results in a 40% reduction in severe exacerbation rates. And I think that there is a very strong and compelling case to be made for changing our treatment target with anti-inflammatory drugs like inhaled steroids. So the use of biomarkers in less severe asthma, I think, is still not guideline recommended. This is a study that I think will change the way we think and potentially lead to changes in guidelines. It's the CAPTAIN study, which was published very recently in the Lancet Respiratory Medicine. And it looked at treatment options on top of ICS-LABA in patients with asthma who had uncontrolled symptoms and who had had one or more unscheduled healthcare visit in the last year. And with the relevant control groups, there were 6 groups of patients, all around 400 patients. And I'm going to show you the data by type 2 biomarkers because I think that was the most compelling result of this study. And if we start by looking at the effects of doubling the dose of inhaled fluticasone furoate, and on the top you can see the effects on FEV1, and on the bottom you can see the effects on moderate and severe exacerbations. On the left by blood eosinophil counts, and on the right by FeNO. And the story is very consistent with what we've seen before. With increasing biomarkers, you get an increasing benefit of doubling the dose of inhaled steroids, whether you're looking at lung function or exacerbations. And I should say that the impact of treatment on severe exacerbations was very compelling. I don't show it here, whereas the effects on moderate exacerbations less so. In contrast, if we look at the effects of adding an additional bronchodilator, umeclidinium, you will see 2 things. Firstly, the predominant effect, as you would expect, because you're targeting airflow limitation, is an improvement in lung function and an improvement in symptoms linked to airflow limitation. There is a lesser effect on exacerbations. These are inflammatory events. There's no reason to suppose that a LAMA would have a big impact on these outcomes. But interestingly, in patients with lower biomarkers, so low blood eosinophils and FeNO, there did seem to be some benefit of an additional bronchodilator, much as we've seen in the COPD impact study. So these biomarkers are allowing you to much better identify the treatment option that is most likely to help your patient. And of course, in severe asthma, we already know that these biomarkers are of established value. So the peripheral blood eosinophil count identifies patients who are likely to benefit from mepolizumab. You can see the threshold for where you sort of see significant benefit is again around the 150 cell. It's a remarkably consistent value where you start seeing benefits of treatment that targets IL-5. And when you get to eosinophil counts of 500, really these drugs are remarkably effective. They're game-changing drugs, which will in many cases be transformational. And with dupilumab, which targets IL-4 and IL-13, we see again a clear relationship between biomarkers and the response to treatment. So with increasing biomarkers in untreated patients, you see an increased risk of exacerbations, whereas in a treated patient, you see a reduction in risk. And with dupilumab, FeNO seems to be a particularly useful biomarker, as you would expect, because it is a marker of IL-13 activity in the airway. So I think we could start organizing our thinking about treatment in asthma and COPD in different ways. So if our patient is not reaching management goals, and I think we all agree what they are, we want our patient to be not over-reliant on relievers, to be having no exacerbations, to have good symptom control, and to have as normal lung function as possible, we need to assess the 2 dominant treatable traits: airflow limitation and associated symptoms, and type 2 airway inflammation. And we need to offer different treatment algorithms depending on what we find. And this algorithm here sets out the different management approaches we might offer, thereby offering the patient precision management and potentially better outcomes. I think one of the key benefits of this treatable trait approach to airways disease, as it draws a much sharper focus on patients who we don't have good treatment options for. And I would suggest there are 2 big groups of patients that fit in this category. I see a lot of patients who have problems, particularly attacks. They often call them chest infections, who do not have eosinophilic airway inflammation. And I believe that a very important cause of this pattern of disease is infection-related neutrophilic airway inflammation, particularly Haemophilus. And the second group is I see a lot of patients that have symptoms, but no obvious airflow limitation. And in them, many of these have cough reflex hypersensitivity. Now, currently, all too often, these patients are offered more and more asthma treatment. So they don't fit well on our treatable trait schema. And perhaps, I think it's now clear that asthma treatment is not the option is not the best option for these patients. So in the first group, patients who have exacerbations but no eosinophilic airway inflammation, we now know, thanks to the amazing AMAZES study from Peter Gibson's group, that macrolide antibiotics given at relatively low dose and long term have a big impact on exacerbations. They reduce them 40%. This benefit is seen in patients who are type 2 high and type 2 low, indicating that macrolides are interfering with a mechanism or treatable trait that has nothing to do with type 2 airway inflammation. And you'll see on the right at the top that the benefits of macrolides seem to be closely linked to Haemophilus influenzae copy numbers per mil assessed using quantitative PCR. So I would suggest that the treatable trait that macrolides interfere with is infection-related neutrophilic airway inflammation. The other big trait in airways disease where we need better treatment is cough reflex hypersensitivity. And this is the phase 2b study of gefapixant, which is a P2X3 antagonist, and showing efficacy in patients with unexplained chronic cough, dose-related efficacy. And this treatment has just undergone phase 3 evaluations, and it does look like it might be the first treatment we have to offer patients with cough reflex hypersensitivity. And again, a treatable trait-based treatment. We wouldn't have discovered this treatment if we hadn't pulled this group of patients out of the asthma COPD baskets and recognized that they were different. So I'm going to finish there. I hope I've convinced you, or at least made you think about managing airways in different ways. The treatable trait strategy is radically different to our current approach. The indications for a treatment are the presence of a mechanism or a trait, not potentially unrelated symptoms. And the goal of treatment is to suppress that mechanism or trait, not symptoms. There's compelling evidence that the two dominant treatable trait-based approach is superior to current guideline-based management in asthma and COPD. It looks feasible in non-specialist care. I think primary care are desperate to do this, and they will do it very well. It's already being done in severe asthma very effectively. I think that one of the benefits of this approach is it will draw a sharper focus on what we can't do in airways disease. And that's really, it's sometimes as important to know what we can't do as to know what we can do in a disease, because it allows pharmaceutical company to focus on the unmet need. And this will facilitate identification of new treatable traits. Thank you very much.
Thank you very much, Professor. Yes, you have convinced me, but maybe not others. So I'll try and summarize what you've just said, and then surprise you with a guy who's going to join us and make your life difficult in the next 5 minutes. Before I do that, I'd like to say that Professor Pavord has nicely outlined that an easy approach for us is to basically look after a measurable effect of the disease, whether it's asthma or COPD. This measurable trait can be number of exacerbation, can be lung function, a FeNO test, a blood test that measures eosinophil, for example. In somebody who doesn't have high eosinophil, we can presume that maybe this is a neutrophilic predominant chronic airway disease, and then treat them accordingly. If the disease symptoms are mainly due to significant lung function and airflow limitation, bronchodilator is the pathway we should follow first. If the symptoms are mainly due to frequent exacerbation, more than 2, more than 3, depending on the guidelines, treating the exacerbation, evidence suggests that inhaled corticosteroids as an anti-inflammatory or other sophisticated anti-inflammatory treatments such as biologic is the better option for your patient. And he mentioned also nicely that the GINA guideline for asthma and the GOLD guidelines for COPD are endorsing this approach as an easy approach, even for non-specialists. And I can see that's why I like this approach, because I think it's simple enough for a general practitioner to check number of exacerbation, lung function, ICS, eosinophil, and treat the patient accordingly. I'd like, before I pose my first question, to introduce the next speaker who's going to join us for the discussion part, and I'd like to hear his comment on this. Our next speaker is Professor Ronald Bull. He's a dear friend, professor of medicine at the University of Mainz from Germany. He's a member of the GINA Scientific Committee, currently the chair of the German Asthma Guideline Committee, and a member of the German Immunotherapy and COPD Guideline Committee. So he can nicely bridge asthma COPD as a treatable trait approach for us. And he has published more than 300 articles. After your talk, Professor Bull is going to speak on an asthma update. My question for you, and then I'd love to hear what Professor Bull has to say, is which treatable trait, evidence-based, Professor Pavord, is the most reliable and studied trait so far? Is it the number of exacerbation, do you think? Is it the eosinophil, the FeNO with the current appliances, the airflow limitation and the FEV1? Which one would you say is the most reliable? If I find this, this is how I should behave. What do you think?
Yeah, I think if I was on a desert island and I had to manage airways disease and I was only allowed two things, I would take the blood eosinophil count and FeNO. Okay. Because they tell me something really important, because often what we try and do in medicine is predict the future and modify it if we don't think it's going to be good. And these biomarkers tell us about risk. It's become clear, and largely as a result of data we got from clinical trials in the last 2 or 3 years, that these two biomarkers are, as I say, like the airway cholesterol and blood pressure. They identify risk of attacks, which we can modify. And the novel start data in mild asthma and CAPTAIN in moderate asthma is really very compelling. All other things being equal, for whatever your lung function and symptoms, if you happen to have a high FeNO and blood eosinophils, you are at between a 3- and 5-fold increased risk of having an asthma attack in the next year. And I think that's something that I would want to know as a doctor. And I think that's something the patient potentially would, well, I'm sure they would want to know that, and that it would allow them to make better decisions about treatment. And we know they often don't make good decisions about treatment in asthma. I think because they don't get it. We're asking them to chase the symptoms, and often they're not asking for that to happen. They're more worried about, ending up in hospital, being unable to breathe, and having a medical emergency. So I think that those are the two tests I would rely on. I'd also want a spirometer if you would allow a third. I definitely want a spirometer or a peak flow meter.
Thank you. That's actually very important and nice to hear from your side. Before I ask Professor Bull again, one last question for you. I'd like you to play the devil advocate against yourself and tell me, what is it that people sometimes don't like about this treatable trait approach? Why is it, I hear in the scientific community sometimes some resistance to it?
Well, I think there's always resistance. particularly when a concept's been so well established, and our guidelines are now essentially 30 years old and they haven't changed greatly in that time. We still have the same basic stepwise philosophy. We're still trying to target symptoms. So there's always going to be inertia. I think to some extent we've been a little paternalistic, saying, no, you can't possibly deal with blood eosinophils and pheno in primary care. You're not clever enough. And if the cardiologists had taken that view 20 years ago, they wouldn't have got where they've got. You know, we need to be, I would suggest, a little bit more aspirational in guidelines to say this is where we would like to get, rather than dumbing things down. And I don't know whether Roland agrees with me. I may be being controversial, but I think sometimes we need to set, you know, this is where we need to be getting. And I think the gold COPD guidelines have done that. They've really led new thinking by separating out exacerbations and symptoms, and in 2019 by bringing in the blood eosinophil count. So they've been very aspirational and led. I think GINA less so. That's my own view. There's been a slight hint of paternalism about them. You know, this is too difficult for you in primary care, which for me is, I don't like that approach.
Thank you, Professor Pavord. I'd like to hear Professor Bull. Professor Bull, thank you very much for joining us for the discussion part of this talk. What do you have to say about this topic, sir?
Hi, Ashraf, and hi, Ian, and dear colleagues. First of all, I more or less completely agree with what Ian said. And I think severe asthma, as he pointed out, and also COPD is a very good example that we not only need lung function and symptoms, but also the biomarkers. And as he said, my preferred biomarker is eosinophils as well, followed by pheno. And in my opinion, and GINA has adopted this concept for the severe end of the spectrum with no question at all. The only reason why we were a little bit reluctant to also recommend it in patients with very mild disease is simply because we in the GINA committee, we think we are aiming at a global population of patients. And in many countries, these biomarkers are simply not available on a regular basis. And this is the reason, and you will hear it in a minute, this is the reason why we in full agreement with what Ian just showed you about the relevance of inflammation in airway diseases. This is why we recommend in patients with mild disease to just always have a steroid on board, but only use the drug on demand to be, on one hand side, be sure you treat a potential inflammation. On the other hand, do not let patients not take a steroid because they don't think it immediately helps them. This is the only discrepancy, in my opinion, between a complete acceptance of the treatable traits. But I think for the large majority of patients and doctors, this is the way to the future.
Thank you. Thank you, Professor Bull. Professor Pavord, any last comment from your side?
Yeah, I mean, Roland, I agree. I always agree with everything he says. I think we're not too far apart here. Yeah. And of course, the use of as-needed ICS rapid onset beta agonist is a very, very important move in the right direction. And I think it does liberate us to begin to think about, well, who should have regular treatment and what should it look like? And it allows us, I think, to more easily do precision medicine, but really focusing on the regular treatment. So I think we're not too far apart.
No, not at all.
What we now need to do is to see real improvements in outcome. And I really do think we can deliver something near to what the cardiologists have done in the next 10 years. And that would be a great goal for us all to have.
If I may follow up on this, Ian, you will always be remembered for a quote which is on many of my slides and which I've heard from many other colleagues. Deliver the right drugs to the right lung rather than more drugs to more lungs. And I think this is just perfectly describing what you and we all have in mind.
Yeah.
I have to agree with everything that both of you have said, except the part of Professor Pavord praising cardiologists. I made the big mistake of inviting some cardiologists today, and now they wouldn't even look at me because they're so full of themselves now. after
No, but they've had their decade. It's ours now. The next 20 years is ours. But I
have to
fully
deal
agree
with
with
that
you, and
on
I do
Sunday.
apologize to the audience for talking too much about cardiologists. That was a mistake. Sorry.
Thank you very much, sir. Professor Pavord, it was such a personal pleasure for me to have you with us today, and I wish you a very safe weekend. Stay safe. Bye-bye.